So, welcome to the Joy of Learning podcast. I am so excited to have our guest here. We have Dr. Teralyn Carter. Dr. Teralyn Carter, how are you doing today?
I'm well. Thanks for having me, Joy.
I'm so excited to have you here. And one of the things that I think is really important, we have October coming up. And so typically in October, that is Breast Cancer Awareness Month. And so I really wanted to reach out to you to see if we could spend some time and talk about it, because it's something that's really important, especially for women and specifically Black women. So I just wanted to spend some time and be in conversation.
Sounds like a good plan to me.
Yes. And so where are you reporting from right now?
I am living in New Jersey now, and I am working at a hospital in Camden. So it's a tertiary referral center. It's a pretty big hospital. We have an affiliation with a large cancer center, which is great for us and what we can do for our patients. And so I'm in New Jersey, back home.
Okay, back home. Home is where the heart is, right?
Yep.
Yes. And where did you come from before you landed here back in New Jersey?
I've done my training all over. So while I grew up in New Jersey, I left about the time I went to college and ran around the country to figure out where I needed to be, which is back home, clearly. So
Yes.
I did my medical school in North Carolina at Duke. I did my general surgery training in Denver at University of Colorado. And then I did my specialty training in breast surgery in Atlanta at Emory and the famous Grady Hospital.
Wow. Wow. So you have been all over. And then the return right back home.
Yeah.
And so I think that's really powerful.
Yeah. Close to family.
Yes. Especially in this time. It's nice. I don't know what it is. I think sometimes we have those full circle moments, and it seems like this is one of them. So, I mean, I think that's really awesome. And so I wanted to talk a little bit about your educational journey. Pretty much on your educational and professional journey, what inspired you to become a breast surgeon?
Well, I was always going to be a physician. So it was kind of what area would I end up in. And when I went to medical school, I thought I might be like one of our former classmates, Dr. Celestine, who ended up in OB-GYN. I quickly realized that wasn't for me, but I did need something that was hands-on and procedural. Okay. So I ended up in general surgery. Wasn't the most direct route, but I did end up in general surgery.
Yes.
And then from there, I just had to figure out, I think the basis of this is that I'm kind of selfish. So I want to see my work be appreciated for many years to come, right? So I want to be able to see people be happy with the outcomes of what happens. And the best way to do that is to treat cancer.
Wow.
And when you treat breast cancer, people have really good survival.
Yes.
And then they follow with you forever and ever and ever and ever.
And ever.
Because most of the time, when you catch a breast cancer early, people are more likely to have their ultimate demise be from something other than their breast cancer.
Oh, wow.
So it kind of fits with me being able to see my work live on.
Yes. Yes. I mean, the outcome and the impact on lives, especially for the time being or for how many decades or years to come. I think that's powerful. That's very powerful. Okay, so here you are, you're a breast surgeon, and you said it didn't take would you say it didn't take the typical route or expected route?
Yeah, I went to residency and I took some time off after my first year, after my intern year, and kind of explored life away from medicine because I hadn't had that. And a lot of people take a gap year after undergrad before going to med school, and I went straight there. A lot of people in my medical school took extra years in school to get other degrees, explore things outside of the practice of medicine. Some people ended up in jobs that weren't practicing medicine, but more consulting and such. And I never took that time. And so I took some time after I started residency and then ended up back where I started, interestingly enough.
Yes. And so how was that year of exploration for you? What do you feel like was the biggest thing you took from it?
It was 2 years,
okay, 2.
Which is extra untypical. And I have to report it all the time for licensing purposes, which kind of sucks. But alas, it is what it is. Anything more than 60 days of a break, you have to report on anytime you want to be licensed or get credentialed anywhere. Yeah. after you graduate from med school. So anything before that is fine. But after you graduate, you have to report any break more than 60 days.
Okay.
So, I just sort of realized that there are things to enjoy outside of medicine because I never had taken that break before. And I was always so
Mhm.
focused on my goal, but like I have hobbies. So
Yes.
I have things to do when I'm not at work, which is a good thing.
Yes. 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 I mean, looking at the whole person, what you're able to
Yeah.
enjoy. And so
Yeah.
it's still awesome that you did take that break in between and that self-awareness to recognize that you needed that break. And so,
Yes.
and then being able to jump right back into it, like that speaks for itself.
Yeah.
So nice. And so October is an important month of bringing awareness to the impact of breast cancer. In what ways can we promote awareness, especially amongst communities of color?
I think it's important to have a seed, right? So one person who is not medical can make a huge difference to their community because if you start bringing along one person with you because
Mm-hmm.
you trust the doctor that you're seeing and
Mm-hmm.
they've told you to do this and you can bring one person with you and then they'll bring one person with them and then they'll bring one person with them, you get this chain reaction.
Yeah.
And our community is very much based on that, right? So we're
Yes.
going to accept the things that the people that we trust closest and the most around us tell us are good things to do. Not
Yes.
just because we just accept them, but because we trust these people. And if these people are saying, I want to save your life by getting you screened for breast cancer, come get a mammogram,
Mm.
and you do it, and we find a cancer early and we treat you and you go on living your life, that's a great thing. If
Yes.
that person just goes and gets their mammogram and is like, oh, I'm fine, and never tells anybody, and then you
Mm.
find a lump and then you don't do anything because no one
Mm.
encouraged you to, because you don't have somebody that you trust in the medical field or you don't have a good primary care or whatever it is, and then you end up in an advanced stage cancer and you don't have the best outcome, that could have been helped with just one person saying, oh, I'm going to get my mammogram, come with me.
Yes. Hmm. That chain reaction. Do
Mm-hmm.
you find that in our community or in the Black community, do you feel like we're having these conversations?
I sometimes think we do, but not always enough. So I get to do outreach through the hospital during October. So we do some lectures and community outreach things. And so I hear my patients say, "Oh, I saw you," and so I decided I was going to come see you because I saw you and you look like me. And so then I told my friends about you. And so
Mhm.
they're going to get mammograms. So I
Wow.
think that it just starts with one. You just have to get
Yes.
one in the door and they will tell their community. And whether that be because I go to the church or because I did this Zoom from the hospital or whatever that was, if I hit one person from that, then that will add to who else is affected by it.
Hmm. Yeah, it reminds me a little bit of word of mouth.
Yes.
I mean, I think word of mouth is still powerful compared to whenever we're thinking about, okay, marketing, because you always have your marketing, right? But there's
Mhm.
something about when people, you have rapport with people and they have
Yes.
relationships that it leads to sort of those better outcomes in terms of, hey, go get this checked or hey, go see this person. So I love how you brought that in because most people wouldn't, I would say not most people, but a lot of times that's not the first thing we think about. We don't think about those initial conversations.
Also, as Black women, we spend a lot of time taking care of other people and not taking care of ourselves, whether it be your children, your grandchildren, your husband, your wife, if that's your choice, or whoever else in your family needs taken care of, the people at your job, whatever it is.
Yeah.
We spend a lot of time taking care of our community and not taking care of ourselves. And I have to tell my patients a lot of the time, you need to take a step back. This is your time to take care of yourself and get your community to support you. They will. If you've been supporting them, they will. And they do. They show up for my patients. And if you don't, most cancer centers have a support system to help you if
Okay.
you don't have that community. So, we have things to help you. And people get so much anxiety about just going to get the screening because what if I have cancer? Well, then we treat it because we caught
Mm.
it early and then you can go
Mm.
on living your life. This is a blip in
Mm.
the entire picture of your life.
Mm.
2 years of treatment, if that, and then you get to go on being your normal self. And during most of treatment, you get to go on being your normal self. So let's just get through it, is basically what I have to tell my patients. And then you can enjoy seeing me every year while I check you and check in and see how your family's doing and your kids and your grandkids and whoever else is born and where you went on vacation. And one of my patients went to Puerto Rico between surgery and radiation. Oh, wow. And so she came back for a 6-month visit and is showing me all the pictures from her vacation. It's not top life when you get diagnosed with an early cancer. So, and I like to get to know my patients. So most breast cancer doctors do.
Yes.
So we create this rapport, and that you have the community in your cancer center too, so that you trust your providers. But I think the really important part is bring someone with you. And if we get that message out to people, then more people are reached to get screened.
Yes. And that's powerful. Now, of course, you brought up early identification. However, I also would like to talk about outcomes. So outcomes for women diagnosed with breast cancer, they vary. Could you elaborate on the disparities which exist between Black women and white women as it pertains to diagnosis, subtypes, and mortality rates?
Yeah, so when we look at breast cancer, all comers in the United States, a stage 1 cancer, which is an early cancer, which is what we look to diagnose with mammogram screening, the 5-year survival rate is 99%. Right. Oh. So I tell my patients that if you're treated appropriately, that's the disclaimer. If you go through the appropriate treatment that is recommended for you, then the 5-year survival rate in a stage 1 is 99%. Okay. So I tell my patients that we don't look at things in 5-year intervals because we think that your lifespan is only 5 years. We look at things in 5-year intervals because it's easier for us as physicians to digest. It's easier for us to give out information in 5-year intervals. So if you are diagnosed with a stage 1 breast cancer and you go and get treatment, you are going to be more likely to die of anything else in your lifetime than your breast cancer. Okay, so that means your heart disease, your diabetes, whatever else it is that you have health-wise is more likely to end your life than breast cancer is.
Wow.
Because after treatment, the recurrence rate or the rate of a new cancer is pretty low. It's less than 1% per year, right?
Okay.
But when we look at diagnoses between white women and African-American women tend to be diagnosed at a later stage. Okay, so that means that off the bat, your survival rate is lower because as we go up in stage, the survival rate goes down. So if we're diagnosed at a stage 3, we're looking at maybe like an 85% survival rate in 5 years, which is still good, but it's not great. Okay. Yeah. And stage 4 is even less, though some of those people in stage 4 who are widespread disease, we are getting to live longer through advancements in medications, but it's not great. Okay. So the deal is you have to get screened. If you don't get screened, we don't catch cancer early. So we're starting out at a later stage, then we're not going to live as long. Okay. Yeah. But then it turns out that there are probably stage for stage some differences in survival too. So even in a stage 1 where the overall comers are 99%, the African-American patients are a little bit lower than that, which sucks. That's not cool at all, right? So what are the reasons for that? We don't have clear answers. Some people say biology, but then let's look at the biology of race, okay? It doesn't exist. Race is a social construct. It is made to be able to divide people and say someone is better than another one, okay? So it's not because of race per se. Maybe there is some biological component to it, but it's not what we see on the surface. When we look at time from diagnosis to treatment, that could be a problem. There's often a disruption in the chain of events between diagnosis and getting to your first visit and then getting to your first stage of treatment when we look at the difference between white Americans and Black Americans. So that could be something. It could be your support system in getting you there. That could be something. It could be that you have chosen a place where the providers aren't as skilled in taking care of you and they're not doing the treatment by the guidelines. I don't know. It all just depends. But I know when you walk into my office, I'm going to treat every individual as a person.
Yes.
Not as, not as something I read in a book, but a person that's sitting in front of me who I just met and who has goals for their life, and that I'm going to try and make sure that you meet those goals appropriately, simply put. So it's important to look at the person that we're treating and not just the numbers about the people that we're treating, right?
Yep.
There's also, and now I feel like I'm off on a rant, so I apologize.
No, that's okay. No, I'm listening. I'm just taking everything in.
There's also the average age of diagnosis of breast cancer is 62. Okay.
Oh, wow.
So that's postmenopausal women. Yeah. And the most common subtype of breast cancer is a hormone responsive breast cancer, which has better outcomes. Okay. So when we look at that, Black women are more likely to be diagnosed at an earlier age. So it may still be postmenopausal, but you may be in your 50s when you're diagnosed instead of your 60s, or your 40s as compared to the white woman who's diagnosed in her 50s.
Got it.
So that probably plays a role in the differences too when you're diagnosed at a younger age.
Okay.
So when you're diagnosed at a younger age, you have a longer life to live. So your lifetime risk is going to be higher of reoccurrence.
Okay. That's a lot of information. But I mean, a lot of times I think society, we always want that black and white answer, and there's more to it. And so I think that you're bringing that out, and that's really insightful. Based on what you were sharing, the average age is 62. And so often I know that I've had a friend who was about 30 that was diagnosed. And then I've also had a colleague who was very close in her mid 40s that was diagnosed. Is that typical to see those who are younger than 62 that are diagnosed?
Definitely. So average means that you have a high age and a low age, right?
Yes.
But that's sort of where we see a lot of the cancers around in the mid 60s. About 2% of breast cancers are diagnosed in women under the age of 40. So 2% of the total breast cancers are diagnosed in women under the age of 40. Okay. I think that number is from the last 2016 data, I believe, is the last that the American Cancer Society published. So it is a low percentage of women that are diagnosed in that age range, but there are women who are diagnosed in that age range. They tend to present at a little bit higher stage when they're under the age of 40, because that means that you felt something, because we're not screening women under the age of 40. But we're very aggressive in treating women so that they can, again, go on and try and live a long life. So
what is the recommended age for being screened?
It depends on what guidelines that you're looking at. There are a lot of bodies of governing bodies that release guidelines. So the U.S. Preventive Services Task Force says that we really shouldn't be screening everyone before the age of 50. They say we can talk about it, and some people should be screened, but not routinely. Whereas most of us in practice use the American Cancer Society guidelines because it captures more people. And so if anyone asks me, I will always say that you should start screening at the age of 40, and you should be screened yearly, unless you have a good reason not to. You should be having a mammogram every year.
Okay. And so in the meantime, let's say you're under 40, you should still be doing checks.
Yes, you should be doing self-breast exams, and those have been taken out of a lot of the guidelines recently. And so instead of calling them self-breast exams, we call them self-breast awareness. Okay. So you should know. You should know what your breasts look like. You should be looking at yourself in the mirror, and you should know what your breasts feel like. Yep. Okay. Yes. Because you live with them every day, so you're going to know them best.
Yes. Yes.
And it is never a problem to say, I felt something that doesn't feel like I normally feel, and go see a doctor and ask about it.
Okay, for sure. Okay.
Also, when you're seeing your gynecologist, or if your primary care does sort of the female exams for you, then they should also be doing an exam for you if you're an adult.
Okay. Well, thank you. That really provides insight. And it's really helpful, because a lot of times you hear information, but that's not necessarily accurate. accurate. And sometimes fear comes into, especially if you have a history or if you have a family history of breast cancer. And so I'm speaking sort of for myself too, because that fear sometimes that comes in. And so that's really helpful and definitely insightful.
Yeah.
So in what ways, I mean, there are the disparities, but based off of listening to you, it seems like those disparities are addressed or can be addressed in different ways, and not necessarily one way per se. Would you say there is one way to address the disparities that we see?
No, I don't think so. I think it takes a lot. It takes the community and it takes providers acknowledging that there's a problem that we need to fix. So, it's very in vogue right now to have diversity teams in your hospital and in your practice, and making sure that you're hiring diverse people or you have your diverse patient population. But that doesn't mean that everybody actually cares, simply put. So you need the people that care to do the work. And I'm in a place where people do care and are doing the work, but that, isn't everywhere per se. It has been my experience in all the places that I've been, that I have been able to step into a group of people that care about the disparities and want to make sure that everyone is getting equitable care. But all you have to do is look on the internet to see some bozo talking about why they don't believe that there's a disparity or why they don't believe there's a difference or whatever, who call themselves a professional. So it does take people on the professional side to acknowledge that there's a problem to try and fix it. And it takes patients being able to trust their providers and providers looking out individually for their patients, but also community looking out for community.
You know what? That's a theme in our conversation, community. So if I were to think about a word that's been repeated that I hear from you, it's really community and how essential community is. And so I think that that's really powerful to hear.
The motto of our cancer center is "No one fights cancer alone." And it's very appropriate, because you need people around you. And what I keep saying about community, you need people to support you. You cannot get through a cancer diagnosis by yourself, no matter how early it is and no matter how easy I say that it's going to be. We just take something out and move on. You still have a cancer diagnosis and you still have to deal with that. You still need support.
So recently, I saw that you wrote an article, 5 non-cancer related reasons you may need to see a breast surgeon. So what prompted you to write this?
A couple of things, actually. Our marketing team said, "Dr. Carter, can you do something to help market yourself, write a blog?" And I was like, okay, I'm not really a great writer, but if you tell me to do something, I'll figure out something. And it occurred to me that even though I am a breast cancer surgeon, I do operate on a lot of things and see a lot of patients who don't have cancer. But my office is in a cancer center. So you come to see me and you might have some anxiety for the fact that you're going to a place that says cancer center. And you don't think that you have cancer coming in, but you're going to see a doc in, again, cancer center. And so when I talk to patients, then they relax and they know that I see patients that don't have cancer too, because I'm a breast specialist and there's no one else that does what we do as breast specialists. Yes. But if I can allay some of that fear before you get to your appointment with me, then it makes it easier for both of us, simply put. Yes. And so it was sort of a quick tidbit of things that I see a lot. That may or may not require surgery, but aren't cancer.
I mean, that was when I saw the article, I was just like, oh, I guess I didn't think about that. So I thought that was really insightful. And I think it is something that people should know. I'll definitely include a link inside of whenever I do the description of the interview so people could read it. Because a lot of times we sort of typecast and we say that, okay, this is the only reason to see a breast surgeon or breast cancer surgeon. And there's other reasons that could come up. So I really found that insightful.
The other thing is there are a lot of things that are pretty common in breasts that people have and they just don't talk about. And then they have anxiety about going to see someone because you don't know that your cousin had the same problem, or you don't know that your best friend from forever had the same problem.
Okay.
Like breast pain. Breast pain to me is a thing that happens when you have breasts. And I see a lot of patients with breast pain and they think that it means that they have cancer, but 99% of the time it does not. And we just don't talk about it with each other. And so I feel like it's important to talk to your friends. We're back to this community thing about what's going on with your health, because it helps other people know that they're not alone and they're not crazy. It's the same thing with mental health. If we talk about it, then people are more willing to get help for things and take care of any sort of problems that they have health-wise.
Okay, so I have a transparent moment. And so I didn't know, of course, so I breastfeed and I breastfed, and I did not know about the blocking of the ducts or sort of this buildup. And I have to be honest and say I freaked out a lot. Because I'm like, well, I have lumps. I have lumps under my arm, and like I didn't.
And no one talked to you about it.
No, they don't.
You have friends that have breastfed, I am sure, and no one told you.
No.
Listen, everybody I know that knows that I'm a breast surgeon that is having children has no qualms asking me about their breastfeeding problems, or I felt this while I was breastfeeding, or now my breast hurts here and I got this, and then it gets taken care of, like easy, right?
Yes.
But you don't know because no one's going to talk to you about it until you're like, oh, I'm a breast surgeon, and now you get to share information. It shouldn't be like that. Like, if you just talk to your friends and the community is chatting with each other, then you still need to see me so that we can take care of the things sometimes, but you don't have to worry as much.
Yes. Sitting in the shower. Oh gosh, I don't know. I'm going back to the first time and I was like, oh my gosh, what's going on? I just didn't know what was happening with my body. But again, there comes community. And also talking about some of the things that are not so pretty and that could be ugly. And I mean, I wouldn't say, okay, I'm not trying to say breastfeeding's ugly, but some of the things that aren't great to really talk about. Because the first thing that I remembered, of course, this is breastfeeding, but I remembered magazines where the baby just latched on and it's like a beautiful day. Sorry, that wasn't my experience.
That doesn't happen for most people. It can be a struggle.
I was like, this is disappointing.
And people don't talk about that until after you're having problems. Like, someone should warn you in advance. It's not always that easy.
Yes, I mean, community, again, we need our communities, and we have to have the conversation. And so these are great points. Thank you so much. So I thought I asked this question. So how do you find joy?
You know, I find joy in all sorts of things in my life. I find joy in my patients doing well. And I think they get a little shocked sometimes when they come back 6 months after, and I'm like, so how do you like it? How do you like the way your breast looks? You know, because I'm doing surgeries on an area that is very cosmetic for people. Yes. And a lot of people's identity is very tied to it, right? So I don't want to just take care of your cancer. That is my main goal when I'm taking care of a breast cancer patient, or when I have to do something that's benign to take care of it. But I also need you to be happy with the outcome. Wow. So when you come back and you're happy, that makes me feel happy, right? Because I told you all the things that can happen. Mm-hmm. And here we are after surgery, and we're looking at your breast, and you're happy with your cosmetic outcome. You're happy with how your breast feels. You're happy with the treatment that you received. That makes me happy. It makes me happy to do things in my life outside of medicine too. My whole identity is not tied to my job, right?
Yes.
So I really like baking and cooking. And I like to bake on the weekends, and I'll bring my baked goods to my girls in my clinic on Mondays. And so my girls in my clinic on Tuesday and Fridays got jealous. They didn't get the baked goods. So one of them politely demanded for her birthday cake. So I made this cake that I found on the internet. It's like a yellow butter cake type thing with a fudge layer between the layers, and then this caramel frosting, and it had like chocolate on top of it and everything. Yeah. And they were just so delighted that now everyone has told me when their birthday is. And I can't always bake during the week because I just don't have the time to make these elaborate things. And so they miss out a little bit. But yeah, I spend time in my kitchen and it makes me happy. And I don't always eat all of like I can't eat whole cakes by myself. So I'll share it. And my dad's down the street now. So when I'm baking, he'll like show up at my house and like give me with his packages saying, give me some.
Wow.
But I find things. I find joy in working out. I find joy in, you got to take it where you can, frankly.
Yeah.
There's so much going on in the world. You got to find it where you can.
Yes, that is so important. It's important to find that joy. Because I mean, if there's one thing that I've learned, it's, well, we should know this, right? Tomorrow's not promised. And so we're literally on a journey day to day to day. So, and even though it doesn't feel like it, it seems like things are permanent, but they're not. So we have to find joy and enjoy each day. I have to have some of your cake though. So I have to figure something out eventually.
So sometimes, I will show pictures on social media and then I'll get messages from people sending me their addresses too. And I'm like, I don't ship.
Oh no. We can make that happen, right?
If you want cake, you got to show up at my house. I did make a special delivery one time last year. Well, I guess it's like a year and a half ago now. Before I left Atlanta, one of our friends from college was like, I want a cake. You keep baking these cakes and you're not giving them to anyone because we were in quarantine, right? So I just make myself cakes. And one of my coworkers, we'd eat my cakes and her husband would eat them too. And then, so I went to his house. So I went to my friend's house and made a cake before I left Atlanta. But,
Oh, wow. Oh, okay.
Basically, if you want cake, you got to come to me.
Okay. Yeah, it's about to come. It's about to happen. I'm coming back to visit. Well, this has been fantastic to talk with you, Dr. Carter. I think what you have shared is impactful, and certainly the audience and those who hear it will also be empowered, encouraged in the process.
Yeah. I think moral of the story is we, no matter what, you need your community and you need to uplift your community, and doing well for others is going to be well for you too.
Yes.